So when looking at an EKG, atrial fibrillation will present as an irregularly irregular rhythm. Normal is a regular rhythm. This will be irregular in irregular intervals. The other thing, there'll be an absence of what's called a P wave. The P wave designates when the atrium contracts. And since in atrial fibrillation, the atria are kind of wiggling and not fully contracting, there's no discernible P wave. There's only sort of a wiggling baseline. So those are the things that most commonly will be pointed out on an EKG of somebody who has AFib. I'm Dr. Rob Norris. I'm a family physician here at PartnerMD. And today we're going to talk about atrial fibrillation and some of the measures you can take to identify it and try to avoid it. The symptoms of AFib most commonly are none. It's usually picked up on a routine electrocardiogram. However, if you do have somebody who's having symptoms, they usually are going to have fatigue, particularly fatigue with exertion. Lightheadedness is another one that can present as AFib. And then there are some people that are very, very symptomatic and can be unstable. So it varies a full spectrum, but ironically, a lot of people don't have any symptoms at all. The way that system works is electrical. So you have a point in the right atrium that's your pacemaker called the sinoatrial node. When you have atrial fibrillation, the pacemaker is not operating alone. You have multiple areas in the atrium that are all firing at the same time. And so that leads to very disorganized type of activity in the atrium. So instead of contracting, now the atrium are wiggling, and the atrial rate is going very, very quickly, often over 300 beats per minute. And because they're not contracting, when the valves open, now blood is just sort of trickling down or falling down into the ventricles. So the ventricles are not really being completely filled. And when they go to contract, now you're not getting the correct amount of blood ejected out to the body. The blood in the atrium is kind of pooling around. And when blood stagnates, it has a tendency to clot. And so particularly in the left atrium, in an area called the left atrial appendage, blood will tend to form clots. And when those clots form, if they break loose, then they're going to drop through the valve into the left ventricle, and they're going to be ejected from the heart. Most commonly, they end up going in the carotid artery, and it leads to a stroke in the brain. There are lifestyle things that you can do, and it's the usual stuff. So you want to avoid smoking, you want to avoid processed food, you want to manage your weight to a healthy level, you want to limit your amount of alcohol, you want to limit your amount of caffeine. There are some misconceptions about some of the treatments for AFib. So for example, when somebody gets cardioverted, and they give them an electrical shock to knock them out of AFib and back into normal sinus rhythm, patients will often think that they're now cured. So the way that I like to explain it to them, it's you walk into your kitchen and one of the overhead lights is flickering. And you walk over to the light switch and you turn it on and off and the flickering goes away. Probably pretty soon, or in the near future anyways, that light bulb's going to start flickering again because you didn't fix the light bulb. All you did was reset the electricity to the area. So that's one of the things that I try to explain, is that the problem is likely to return if we don't do something about some of the things that the lifestyle measures that we mentioned, for example, or medications or procedures. So a lot of times when we're explaining the pros and cons of ablations, patients will say, well, my neighbor had an ablation 3 times and he's still in AFib. What I try to explain to people is that because your neighbor's ablations didn't work out for your neighbor, it does not mean it's not going to work for you. That everybody is different, everybody has different scenarios, different comorbidities, different timing. And so I try to not allow them to let that discourage them, because it can be very successful. So if they're unsure about their heart health, I think starting with your primary care doctor is an excellent place to start. You get an EKG, you get a history, you look at comorbidities, medications, lifestyle, and you kind of get a general sense for what the patient's risks may be. And then from there you can stress test. You could do an echocardiogram, or if you feel the need, you can send them over to the cardiologist and have them decide on what workup would be appropriate at this time.